morning, everybody, and welcome to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association. Today, I am joined once again by Dr. Marty Maron from Leahy, all the way up in Massachusetts. Good morning, Marty. How are you today?
Morning, Lisa. Good. How are you?
I'm okay. It's that week of my life. We're doing this live on June 13th, 2025, marking some historic events in HCM, I guess. 30 years ago yesterday was the day my sister had her cardiac arrest. And that has led to a lot of changes in my personal life, my family life, and my professional life. And I cannot believe it's been 30 years she's gone. So it's a 5-day cycle for us, the loss process. Lori had her cardiac arrest on the morning of June 12th. She was brought to St. Clair's Hospital. She was beyond their capability. She was transported to Morristown Medical Center. They did their very, very best. So today was day 2. She was on life support at Morristown. Today was the day we had hope. Today was the day we thought she'd wake up.
Right.
Today was the day we thought we'd have a go home day and a, wow, we dodged a bullet. So we had hope. Didn't last long. Tomorrow that hope would fade with an EEG showing no brain activity. The next day we would have the conversation about her becoming an organ donor. And then on June 16th, at 4:36 in the afternoon, Dr. Bob Wall leaned down and kissed my sister on her forehead and signed a paper. I later realized that he said, kissed her and signed her death certificate. He left the room in tears. So her death affected a lot of people in that week, but the ripple effect of her life is us talking here today and the community watching and the podcasts and the webinars and the centers of excellence. Everything has Lori's fingerprints on it.
Yep.
So today I remember my big sister in a podcast. There's lots written on her and there's lots about the experience. You can even follow the lawsuit at from the National Institute of Health that followed. Her case and her story connected me with some guy named Barry Maron. And he helped me unravel the mystery in such an elegant and kind way. I got my medical education on HCM via thermal paper fax machine from that point forward, because your dad would send me articles to help me understand what happened to my sister in a bigger way. And we formed an alliance and we started to solve problems together. And I can't believe it's been 30 years. I cannot believe it. I think I'm the age your dad was when I met him, which is crazy to me.
That is crazy. Wow.
So it's been a wild 30 years.
Yep.
And I think we're going to accomplish a lot in the next 10 years. I think we'll accomplish in the next 10 years what we did in the first 30, because we're accelerating and we've got a bigger team and we've got so much more opportunity now. But hopefully, by the time I hit the next milestone here, 10 years, I want to be retired from daily operation. That's the goal. And that's what we're working for today. It's been 30 years already. I've met some incredible people along this journey. I never would have met any of it if it hadn't been for Lori. She gave me the energy to keep going when I didn't know I had it. So thanks for being on that journey with me, Marty. Thanks for choosing this as your career path. Thanks for understanding the importance of the patient voice in the process and helping us elevate that in every way. So that is my preamble for June 12th through 16th, 2025. The other thing I'm coming to understand a little bit better as I age, 5 years to the day before Lori's cardiac arrest, I had a stroke. I was 21 years old. I had endocarditis. I threw a clot, had a stroke. I'm partially blind in one eye to this day, have some residual weakness on my left, which is actually kind of more noticeable as I age. Stroke prevention is important in HCM. I don't think we talk about it enough. It does happen. There are different reasons why people stroke in HCM. And I don't often think of myself as a stroke survivor because that was just kind of part of my HCM journey. But to all of my fellow brain injured folks out there, we can do great things with not perfect minds. They might have some scar tissue in them or might not be functioning like others do, but you can still do amazing things post-stroke. So there's my little message out to my stroke community that I tend to ignore, and I don't know why. So Marty, it is June. We like to talk about being active in the summer in HCM communities and families. We don't want to sit on the sideline and watch the world go by. We want to get out there and do things. How do we safely be active in the summer with our HCM hearts? What do we need patients to know?
This summer, you're alluding to that here, I think, because of the fact that obviously the conditions are a little different than a lot of the rest of the year in terms of just the heat, the humidity, that can have an important factor in terms of how patients with HCM tolerate physical activity. And so, I think what that sort of raises is a couple things. One is that maybe there should be an enhanced or greater, just focus on, listening to your body first, when you are still engaging in mild to moderate recreational level activity outside in the hot summer months. Maybe you alter a little bit more when you do those activities, perhaps during the more cooler periods of the day rather than in the middle of the heat, perhaps. And maybe it's a little bit of thought too on sort of how to, maybe modify in some other ways too here to make things a little bit easier. And so you just have to give things a little bit more thought and be a little bit more proactive in terms of planning and listening to your body. And also, as part of that, of course, is maybe a little bit more attention to staying as hydrated as you can, which is always important, for patients with HCM, period, to keep the tank full. Makes patients feel better just in general, but of course, even more important when you're probably losing more fluids, when it's hot and humid than you realize. I think those are some of the things to sort of be a little bit more aware of. I think we're not saying to avoid, staying active during this time of year, but I think it just requires a little bit more thought.
So let's go back in time a bit, and then let's think about where we are today. For those who've been around the diagnosis of HCM a long time, our messaging has changed from what we're hearing from our healthcare providers. 1980, no competitive sports, no exercise, don't do gym class, sit down, do nothing. To the modern era, where we are encouraging normal activity for most patients with HCM, can you help patients understand why we have evolved our thinking and that it's not, we can do everything, but why did we evolve? How did our understanding evolve? And what can patients rely on today to keep themselves safe, active, and fit in terms of advice?
Well, the first point here, those are all great, great questions. It is a little bit of a confusing area of management, for HCM. And so let's like you said, let's try to unpack some of these things for you if we can. So first, I think this is one of the first confusing areas, which I'm not sure why it's confusing as much as it maybe is, because, it probably doesn't deserve that, which is experts and the guidelines have always said that mild to moderate recreational level kinds of activities, and I can sort of help define what we mean by that in a second, but mild to moderate recreational level activity is not only safe for patients with HCM, but is something we encourage, that patients do. We don't want patients to trade, one disease, HCM, for another, meaning being sedentary, doing nothing, and then having consequences, with your health because of that is not something we've ever advocated. And so I think what happened if we kind of go back in time is that because of the risk of because of the sudden death issue, that got translated in terms of the general practicing community to mean that, if you have HCM, you are, and I've heard this many times, a ticking time bomb, and you can't do anything because of that. And so that's never, though, been the position of experts in this disease, as you know. And then to back that up is that the guidelines, the national or international guidelines for HCM, have often supported the expert opinion, which is mild to moderate recreational level activity is safe and permissible and should be encouraged for the vast majority of HCM patients.
Did everybody hear that for the people in the back?
Yep.
Safe to do moderate exercise.
That's right. That's right.
Next.
And again, what we mean by that too, just so we're 100% clear, is that there's never been any evidence that, with HCM, you would be at an increased in risk for yourself by doing mild to moderate recreational level activity. Okay. There's been never any evidence of that. Okay. Which is why those positions have been supported for patients. Okay. Those recommendations. Let me just preface that by saying, and I think just so we're all clear, and I think we are, because I think this is an audience that understands this though, but just to be clear is that, what we're saying here, we're saying applies to the vast majority of HCM patients. There may always be individual, exceptions or other considerations that, you should always check with your HCM cardiologist about here specifically for you as an individual patient. But what we're talking about, Lisa and I right now, is the general recommendations that have been in place for the vast majority of patients with this disease, which is supported that kind of level of activity.
So that brings us to the next group of people. So we have people who are really, really exercising at a very high level, or they might be competing in a competitive way. How does a patient assess their anatomy with an expert to help determine what level of activity is appropriate for them? This is bread and butter for you. You do this every day. You have these conversations. What are the key things patients need to understand about their individual risks to decide what's right for them?
Well, I think, again, what we say is that for the vast majority of patients, as we just said, mild to moderate recreational level activity is fine. And so what we usually say is that, this is another thing that it gets, so we to kind of characterize that, we say that, for example, it's about the intensity, not the heart rate, for example, for just a minute. And so, right. So what that means is generally that, and a good way to describe that is that sort of at peak level of exercise, after a nice, gentle and gradual warm up, you should still be able to kind of have the opportunity to complete words and sentences if somebody was next to you during that physical activity, and do that in a way that you're in control and can do. Okay. If you're exerting yourself to a level where you can't actually complete words and sentences, that probably is too much. Okay. Again, these are rough guidelines here. And so we use those kind of descriptions as opposed to, in general, giving patients a target heart rate, because that one, we don't really have available, at least evidence to support an actual cutoff for heart rate. And it doesn't work either intuitively, because different patients, would have different levels of heart rates and everything else. So we don't really go there. We don't think that that's one supported by science, but also isn't, particularly a helpful guideline there. And so that's a general way of looking at what level of activity in general is permissible for patients with HCM. On an individual level, again, as we said, there may be some, differences there depending on an individual patient's clinical profile, what risk factors they may have for an increased risk of arrhythmias and those kind of things that, may alter that a little bit. But then again, that's a question and a conversation that would be important for that patient to have with their cardiologist. But for the vast majority of patients, what we just outlined is a reasonable way of how to think about what level of exercise is good. Do you want to ask that at all? Do you think that?
I think
is reasonable.
I think that's reasonable. We are live at 11:30 a.m. on the East Coast. And if you are one of the viewers, you are able to ask questions at any time. So if there's something that's not clear, please ask us to clarify, and we certainly will do that. So I want to kind of do another look back.
So maybe, before you do that, maybe to kind of round this out for a second, the more of the challenge and maybe in some ways the controversy here has not been with mild to moderate recreational level activity in HCM, but rather than with organized sort of competitive sports. Okay. That's really where I think a lot of what you just alluded to when you introduced
Controversy.
Right, controversy, and perhaps a little bit of our shift in thinking has been in that group, really. Okay. And we have to make the distinction between what we just said and organized competitive sports, because those are two different ballgames, right?
Very different.
Right.
Very different.
And why are they different? Because organized competitive sports comes with it a certain different level of intensity, a different level of drive that patients will have that are participating in competitive sports, the drive to, that we all have when we're doing that, to be performing at a level that is meeting the expectations of you and the others that are participating in that. And also the unique environment that comes with organized competitive sports, usually, where you may be subjected to different kinds of levels of adrenaline and intensity and fluid shifts, et cetera, that are relevant potentially to influencing the level of risk that a patient may have when doing that with HCM. Okay. So different ball games here. Okay. And that is why there has been a different level of focus and energy on recommendations around HCM patients who want to engage in organized competitive sports.
So let's go back to the general community for a second, because we have two very good questions popping in here, and I think they really explain like some of the challenges that patients have. So Tim is commenting here that chest pressure is his weakness. He feels like an elephant is sitting on his chest when he does too much. And then right after that, Pam is commenting, my husband gets chest pains when he walks. I don't think Pam is married to Tim, but that's a whole other story. He hesitates to exercise too much because of this. Any suggestions? So when somebody is just exercising and they're coming against a symptom that is limiting them, what should they be doing as patients to discuss that limit with you, and how can you help them?
Yeah, I mean, so a couple things. One is, obviously, I want to be a little thoughtful and careful about giving specific medical advice, obviously, without knowing all the individual patients, obviously all their history and everything. So we're not obviously here to give specific medical advice. But the principle here would be that, in general, would be that, one, we don't ever really want patients to be pushing through physically activities if they've got symptoms that are limiting them. Okay. Right. In this case, it was two patients with chest discomfort. So we don't want you pushing through an activity if you're symptomatic. I mean, that doesn't make sense for a number of reasons. And so we then have to decide, or we have to then at that point, then we have to sort of understand why that is happening, what else could be potentially done therapeutically, maybe to mitigate or eliminate that as an issue. And that's where, really understanding with your cardiologist whether or not there could be other treatment pathways that could affect that in a beneficial way, then to allow you then to exercise in a different kind of way without being held back by that.
I think that is an excellent explanation. And again, we're not here to give medical advice. We're here to talk about generalities.
Right.
But I would really consider, to these patients who are saying they were getting chest pain when they're exercising, have that conversation with their physician. There's workups that can be done to try to figure out the why. Is it because you're obstructed? Is it because you have microvascular disease? Is it because you have coronary artery disease and it's not anything to do with HCM? So understanding why you have a symptom, there's so much in the toolbox now to treat it that we can do more to treat. So that is great. So somebody's asking, can these patients go through cardiac rehab? Now, we've talked about exercise prescriptions for a long time. Can patients get an exercise prescription and go to rehab to learn how to exercise? Is that possible?
I mean, I think it's possible, and it could be an avenue, that one could pursue. Cardiac rehab is generally, more reserved for, short-term, strategies for patients that have usually gone through surgery, cardiac surgery, or procedures where they need to be reconditioned. I think what's being asked here is, can cardiac rehab be leveraged in a slightly different way as a way to craft a exercise program really for patients with heart disease. And there may be cardiac rehab programs that kind of have that option and availability to them. I don't know if they all do, but that would be something that the patients would have to explore with a specific rehab program to see if that kind of pathway is available for them, because it's a little different than the usual routine.
It is different. I know that there are a couple of programs that are doing exercise prescriptions for families as clinical trials, basically like smaller programs. They're typically funded through grants. And if you want to do it outside of that, it's probably going to cost you to do it, but it might be worth it to have some guidance as you learn how to exercise and get through symptoms, or be able to better identify when you're having symptoms so you can work with your healthcare provider to limit those. Somebody else is commenting that they don't have stamina in the heat.
Lisa, the other thing about that the last question too is that, in addition to cardiac rehab programs, but there may be also, for example, trainers, physical activity trainers that, have expertise in helping to craft exercise programs for patients with heart disease like HCM that are not part of cardiac rehab programs, but are sort of more
self-directed
Exactly. That's another avenue to explore.
So the Peter Monk program in Toronto has a great online presence for exercise in HCM, and they have it leveled in exercise tolerance. Right. So you can have beginners, middle, and then high intensity. It's a really interesting program. I do want to get back to the stamina question that Joy was asking. You talked about this earlier. You talked about humidity and you talked about fluid. So I want to take that a step deeper and say sodium, magnesium, potassium are critical to your heart functioning normally. And we lose those nutrients as we are sweating. And if you're in a hot, humid situation, you're going to sweat no matter what. If you're exercising, you're going to sweat. So can you talk about balancing everything we need to balance to have a healthy heart in the heat, and when to just say it's not a good day to exercise for somebody with HCM outside. Let's go inside and walk in the mall or walk wherever we have to walk. But how do people stay safe?
Well, I think like a lot of things, that involve, HCM, there's some judgment here, about that has to sort of fall a little bit with patients in terms of, listening to their body in general, understanding their body in a way to know that, if it's a certain degree of heat that's out there that time, it just may not be worth exercising at that point or being outside at that point. I mean, based on their prior experiences, based on what they know that they can tolerate, from an HCM standpoint in that kind of environment. So I think it's a judgment call a little bit. I mean, there's no exact line in the sand there. I think the principle is if you're thinking twice about it, because it's probably worth not doing it at that point in time, and to reconfigure strategy to exercise or be involved outside at times where it's just it's more favorable, earlier in the morning, later in the evening. And also, you really have to keep up with the fluids. That's a hugely important issue. I think, I can't tell you the amount of patients that feel better when they're hydrated, even in the non-summer months here, that's always something that you may be behind on and don't realize it. So we got to keep up with that.
So Don commented that he personally believes that hydration is very important with HCM and exercise. And Doug, we all agree with you. We agree with your hypothesis there. I would say that as a family with HCM, the first thing that we do when it's a beach day is everybody gets their Gatorade before you get to the beach, and you pre-hydrate before you get out in the sun so that your system is ready, and then you keep the hydration going all day long. Don't wait until you're in the sun or in the heat to start your hydration. Start it when you get up that morning. If you know you're going to be outside, stay well hydrated from ahead. Don't get behind on it. Your fingers look at all pruny. You need to be drinking more. Know the signs and symptoms within your family. And if you're going to have a beach day, or if you're going to go to an amusement park, Gatorade first, then keep hydrating throughout the day. That keeps people more comfortable in one family's experience.
Sure.
So we got chatty people today. Let's see what else is going on. Okay, so somebody who has recent atrial fibrillation and exercise. Let's talk about the AFib exercise group. Are there different guidances for somebody who's prone to AFib?
Yeah, I mean, in general, for the vast majority of patients, again, we're talking in general, because I'm not going to get into specific, right, individual, but in general, particularly for the level of activity that we're talking about for HCM, that level of activity usually does not represent a trigger for atrial fibrillation for patients, okay? In other words, there isn't any clear evidence that by doing mild to moderate recreational activity, that you're going to increase the chance during that activity of having or producing or triggering, I should say, atrial fibrillation. Now, there may be some patients where that, that exercise may in fact, be a factor. That's where you have to talk to your cardiologist to better understand your situation. But that's not the rule in general for most patients, okay? So we try not to exclude patients with AFib from continuing to stay active based on that principle.
So now I'm getting some flash from saying Gatorade. There are low sugar Gatorades, but you get your electrolytes as well. So any electrolytes rich drink is what you really need to keep going throughout the day. Water between, back and forth. That's what's worked for my family from a personal perspective. You may need more sugar, you may need less sugar, you may need more water, but stay hydrated. So water is good. Water bottles, buy you all the time. I fill up at the gym fountain before you get on the treadmill. Hydrate before exercise and during, but make sure you're doing it beforehand too. So when we get down to the recreational, high rate during exercise, no symptoms, okay. Carol, I can't really comment on that here. We're not going to comment on that one because that's a very personalized situation and there's too many variables there. So if you want to have that conversation, call the office, do an intake and navigation, and we can get down to some more guidance for you there. In terms of why there's been a shift potentially in risk tolerance for some level of athletic participation in the HCM community, it's because of the advancements we've made in AED and CPR preparedness, that God forbid something bad happens, we have better emergency response systems in place, as evidenced by two events. First event happened in 1990, and it was the death of Hank Gathers, which was filmed. I don't recommend anybody with HCM go watch that film. It's very triggering and it's very sad. But basically, he goes down and nobody does a thing to start resuscitation because they didn't think about it in 1990. Nobody started CPR. There was no AED. This poor young man dies in front of people. And then you have, not from HCM, but we have the event that took place live on Sunday or Monday Night Football with Damar Hamlin, where he has a commotion cordis induced cardiac arrest, we believe. And in like minutes, the entire EMT team was there. They had a professional response, and he was resuscitated successfully. That's 30 years of scientific advance and public health education in action. We're better. Doesn't mean it's always going to be there for everybody. That response, you're not going to duplicate on a recreational sports field. That was a professional response with professionals. They're not at your kid's football game. So we can't rely on that level of response. We have to have the right patients risk stratified to make sure that it's okay for them to participate safely. There's no guarantee of safety. There's no zero risk factor for sudden death, but we know low and high risk. So I think those changes have changed who can do competitive athletics and who shouldn't. Marty, is that a good assessment of where we've come in 35 years?
I'll add that I think, one of the other points here too is that, one of the reasons too that has contributed a little bit to this shift in competitive sports with HCM, which is what you've been talking about right now, right? I mean, that how to approach that with HCM patients, right? A couple things just to add is that, I think there's been, some studies that have suggested that possibly that risk of sudden death, with HCM in athletes, may not be as high as other studies. And so there's been a little bit of, some recalibration in some eyes about the magnitude of risk being a little bit different than it was perceived to be in prior decades. I think that's also coupled with the idea that there should be more opportunity for patients with HCM who want to engage in competitive sports to have more of a opportunity to say whether they believe that that risk is worth taking or not. In other words, that the patient voice, what we have termed shared decision making, has been given much more weight here in a situation where the risk of an event, an adverse event for a patient with HCM during competitive sports, may be increased, but the quantity of that increase may be overall pretty small, for that patient. Okay. And so I think those ideas about how we look at risk in this situation, both as physicians and patients, has also weighed in on kind of helping to evolve our approach to these patients who want to play competitive sports as well. So that's the other factor.
So we talked about this briefly before the podcast. I just do want to bring up that there has been a recent sudden death of an athlete that's probably going to make some news over the next couple of days. He was a former NCAA 1,500 meter track and field runner. I don't know his cause of death yet. He's a young Black man. And then we also have a YouTuber by the name of P2 is the name, is his YouTube name. His name was Philip, and he passed away on March 14th from what they have autopsy determined to be HCM. He's not an athlete. So we still have people who die unexpectedly, and we have the undiagnosed. That's a whole other group of people. And not that we're not going to pay attention to that group of people, but the diagnosed patient today has the ability to have risk stratification and proper assessment to determine if they need a defibrillator, if they don't, if they should play, if they shouldn't. That's where expert opinion comes in and expert care comes in. We've not gotten rid of sudden death, but we've decreased it exponentially over the past 20 years. It's been amazing. We're getting someplace. But there's not a connection between sports and sudden death that is something that should stop people from doing exercise.
Right.
That myth has got to die, and we have to bury it. Exercise, mild to moderate exercise is safe, and patients should feel reassured. Correct?
That's 100% correct. And this idea that isn't true, comes from this old idea that it's unsafe it was never founded. It's an unfounded idea. It was a reaction that, unfortunately, permeated into the culture of a lot of practicing physicians, but had no scientific foundation to it, as we talked about earlier. And so it's been one of the unfortunate parts of the HCM story, in a way, is that I think, and I think you would agree, that got permeated in such a degree that it really affected the lives of many patients, because it created a restraint that didn't have any basis to it, and affected many people's lives because they weren't able to stay active, and traded one disease for another for really no reason other than an improper reaction to risk related to this disease. And so we are in the process of helping to reverse that right now. There's no question about it. And so, but it takes time, because it was such an ingrained part of the culture that it's going to take more and more time to change that thinking.
So for those of you who've listened to Tales from the Heart before, Seth Pullen is somebody that I've interviewed before about his experience with his ICD in athletics. He's commenting here that the best decision he ever made was to get an ICD, and I think Marty knows that story too. So Seth, glad to hear from you. So as we kind of just round out the topic that has probably taken up way too much time in HCM space, if you are a competitive athlete with HCM, go to a center of excellence, get assessed, and determine what is safe for you, and make that shared decision to do what it is that you want to do. You're an adult, it's your life. If it's a child, the things are a little bit different. Pediatrics we view a little bit differently, because we want to protect children a little bit more, because they can't make those cognitive decisions for themselves as to what level of risk they can take. So peds, I kind of put that in a box, and we're going to be talking a lot more about pediatric HCM in the coming months. as we have a number of new centers joining our programming that are pediatric programs. So you'll hear more about the peds concepts here. For now, I'd like to just should have probably said this in the beginning. We're really talking about adults here, talking about adults and exercise in HCM. Although the recommendations for children and HCM families are pretty much the same with recreational activity. It's just the competitive sports have to be evaluated differently. Marty, any other final thoughts that you would like to put into this conversation? Any level sets that you want people to be sure that they know?
No, I think we covered it, and I think pretty well here. I think we emphasized, what are the really important points about the mild to moderate recreational activity that is permissible for the vast majority of patients with HCM. I think we covered that point, and that the organized sports is a different ballgame and really requires, a different level of care and thought and recommendation that has to be, as you just said, really provided to patients who want to do that by experts here to get the right care and recommendation in that area. And I think those are the major take-home points.
So thanks for the wrap up. Joanne threw in a question here, which I think is important. And I think we've even had a conversation about hot yoga at one point in our lives. Exercising in heat specifically for those with HCM, a do or a don't?
Yeah, I think coming from somebody who, found a lot of benefit and continues to find benefit myself personally in hot yoga. And there may be people that can't believe that out there, but actually, yes, I
outed you.
practiced the Bikram form, which is the hottest and most intense. I don't have HCM, and so my engagement doesn't mean anything here in this conversation, other than I understand the attraction and engagement with hot yoga in general. The answer to the question is there's different types of hot yoga. There's different levels of intensity. There's different levels of heat. I think that really is a conversation that if a patient wants to engage in that level of activity, they really should have with their provider to better understand, what their situation is medically, but also, what exactly we're talking about in terms of which levels of hot yoga may be at play here. So I'm not going to address it any more than that, other than to say I'm not saying no, but I think it has to be individualized.
So we had quite an engaged group here today, even though we got started a little bit late. So the themes of the month are exercise and staying active with HCM in the summer months. And then the second is grief and loss. And I opened with the why we put it in the middle of the year that we talk about it. But I didn't prep anything for this one, Marty, but I'm going to ask you a hard question. If you don't want to answer it, don't answer it. I know that as a clinician, you get to know these patients very well, and that you can't win every battle, and that sometimes the people that we fight the hardest for don't make it through for whatever reason, and they break our hearts. Collectively, the community had a broken heart this month for a young girl named Esther Grant Rivas, who was going for a third heart transplant. Things were really complicated for her. I knew her since she's 7. And there's those special patients who just stay with you forever, no matter you did your best and bad things happen. And we try to beat HCM as much as we can. How do you as a physician manage the grief and loss that comes with HCM sometimes?
Yeah, I don't know. I don't know if I could say that I have mastered that, or it is impossible to master that or deal with it. I don't think I think I'm continuing to learn how to deal with that as it comes along too. It's such an intense and difficult situation that carries so much heavy weight with it, as all these sort of tragedies do, no matter what. But as often is the case, that when you take care of patients with this and it happens, it's an enormous amount of weight in a very complex situation often, and one that I've often found, really challenging at times to work through myself. And although I think I've learned a lot and perhaps have found better ways of coping with that, I still think it always is challenging for me personally, obviously, as it is, of course, for the patients and families that are in that kind of situation, obviously. But yeah, I think that's, I don't think I have any, specific, or, I don't think we have time necessarily to go through specific ways that I have helped to cope with that itself. But other than to say that I recognize it's just a constantly evolving challenge, for sure. Lisa, sorry, on that note, I'm sorry, but you
got to run and go be a doctor now. I will wrap with this thought. I just want everybody to remember that when we grieve, our care teams grieve too. And that you guys are human and that you have the same emotions, and it's hard to express them sometimes. So I just want to acknowledge that from the care team side, we see you when there's a loss as well. And we know you try really hard to make this not happen. Your job is to help us stay here. And when we leave, it's hard for all of us. Marty, I can let you run and I can wrap up on some of these questions now. Go be a doctor. And thank you so much for giving us some time today.
Appreciate it.
Happy Father's Day.
Thank you. Appreciate that very much. Have a good week. Appreciate that. Thank you. Always good to be with you.
Give my best to your dad too on Father's Day.
Thank you.
Okay, so we're going to wrap up here. Without him, he was multitasking to try to get to a patient care issue, so we don't want to distract. Stephanie, they're human, and making sure we see them as humans is really important. They hurt too. So Austin, I was advocating for my daughter to get an ICD in Boston. It was crazy. You could easily get hit by a car. People with HCM do have arrhythmias, no center of excellence. My daughter was most likely to do. So we all have complex family histories. We all want to manage our HCM in our lives. We all want to have great outcomes. It doesn't always happen for everybody, but we're getting so much better at it. In the past 30 years, the number of advances in HCM care are too numerous for me to even count right now. But I can tell you from a family who's lost a lot from HCM, it's a really good time to have a really shitty disease. We have more options. We're better at caring for people. We're better at protecting from risk. So please, please, please use the HCMA Recognized Center of Excellence model. Get high volume care. Talk to your care team. Don't tell lies to your care team. Don't always be your best self. Be your real self. You're not always fine. You can say, I'm symptomatic. You can tell them that you're having issues. You don't have to always be stoic. You can be a little bit more vulnerable and let them know how they can help you. I think sometimes as families, we just put on that exterior and go forth. I've been doing this for 30 years professionally now. I am not as strong as you think that I am. I have had my moments that are not pretty. I've had the ugly cry moments because my family's been through a lot. It's okay to let out grief. It's okay to heal. And it's okay to have spaces that are still not healed even after 30 years. So be kind to yourselves and join me in just a few minutes because we're going to come back with Dr. Sam Sears to discuss mental health and HCM. So a big thank you to our sponsors of the Big Hearted Warrior Tour. Joey, insert sponsors here. And I really appreciate all of you being part of this amazing community. Thank you, Stephanie. I'm glad you think it's because of me, but I had a hand from beyond guiding me, and that was my sister. She gave me passion. She gave me purpose. And it's been a hard journey, not going to lie, but I'm certainly glad I'm here with you all today, and we've got a lot more work to do. So stay tuned for more and come join us with Dr. Sam Sears in just a few minutes.
The Hypertrophic Cardiomyopathy Association would like to thank our sponsors, Cytokinetics, Bristol Myers Squibb, and Edgewise Therapeutics.